Well, as you know, this week in our course, one of the things we're thinking about is the role of the pharmacist in our healthcare system. And I'm very happy to have with us in this interview video module Dr. Stuart Beatty. Dr. Beatty is an assistant professor of clinical pharmacy at Ohio State University, and we're going to talk about kind of one specific aspect of that role in the healthcare system which may kind of broaden your thinking. So Stu, thanks for being here with us.
No problem, thank you.
I wonder if you could just kind of start off by describing your practice site to us.
Sure. I practice at one of the OSU General Internal Medicine clinics. It is the primary internal medicine clinic for the residency programs. There are 70 to 80 internal medicine residents that rotate through that site. There are 12 different attending physicians that practice there as well. So we're talking about 20,000 patient visits per year at the site. I am a shared faculty position pharmacist, so I'm there about 50 to 60% of the time. And I have 2 pharmacy residents that practice there with me. We also have a nurse practitioner on the site. We have a social worker that is there. We have 3 registered nurses and anywhere from 12 to 15 medical assistants as well as some other people rotating in and out of the site. So it's a pretty busy place.
It's a busy place. I actually use that site as my primary care provider, and it's a big practice. And you're practicing in a clinic setting, internal medicine.
Yes.
No dispensing of medication.
Correct.
Really, and you're there as a collaborative practice provider.
Exactly.
Yeah.
Exactly.
So Stu, this clinic where you work is designated as a patient-centered medical home. And we will have mentioned this in our course maybe at different times during the period of the time the course is running. But what exactly does that mean? Can you describe it briefly to us?
I can try to describe it, and I can try to describe it briefly.
Yeah, there you go.
Those are two key components there. So to be a patient-centered medical home, we are credentialed by NCQA, which is the National Committee of Quality Assurance, and we have the highest distinction, which is a Tier 3. There's 3 different levels. And essentially what you get ranked on as a clinical practice or as a physician practice is increasing access to your patients, using an EMR, making sure that records are available to multiple people, being multidisciplinary, so I talked about all the different professions that are represented at our site, and we want to make sure our patients have access to us. So that means not only do they have access to patient visits and they can get in quicker, but we also use email communication and telephone communication to them. And we also do some reporting and use some quality improvement projects to make sure that we're actually doing the things we need to do. And you submit all that stuff to the NCQA, who then gives you the recognition. So we are the Tier 3 recognition.
Yeah. So it's a complicated concept, really.
Yeah,
and
it really
means
is.
different things to different people. You mentioned EMR, which is electronic medical records,
Yes.
so that's an important piece of this. And is it fair to say, Stu, that this is a kind of a platform for delivering kind of multidisciplinary care around the patient to use all of the skills that we have to help us get better?
Yeah, absolutely, absolutely. I mean, the whole concept of the patient-centered medical home is the patient's in the center of it, which is unfortunately not the way that our healthcare has been delivered historically, but that's really where we're moving. And the EMR is a huge component of that. Just historically, before we had that, I would be just like anybody else. There'd be one paper chart, and then I had to try to fight for that chart, or when I had access to that chart, get as much information as I could, and then give that chart back so the physician could look at it. And now that it's electronic, we can all log in at the same time on the same patient. We can be reviewing records, we can be documenting at the same time with that encounter, have access to labs, have access to any procedure that may occur. I have access as the pharmacist, I have access to that medication list, not only a current medication list, but any medication that that patient has been prescribed before. So it really does change practice.
So, I mean, as a patient, it sounds like that's the way it should be, right? I mean, we would hope that these different people are using their skills and their knowledge about my particular problems.
Right.
So, if we could follow up that idea, can you give us some example maybe of how this has improved a patient's life, maybe something you've done or one of your residents or whatever? How does this make it better? Can you give us a specific example?
Sure. Well, we've been involved in a number of projects at our site that pharmacists have directly been involved in. And when you think about pharmacy, the first place you think of is not the physician office. So we're kind of in a unique spot in that we are right there and we are very collaborative with the physician. One of the things I can talk about is we are involved in a diabetes project, and we've actually been doing this for about 6 years. Of patients that have diabetes in our clinic, they actually come for a collaborative visit, and it's the physician and pharmacist do that visit together. So again, we're writing the note, we're in there getting the history at the same time. pharmacy is often involved with following up with those patients and dose titrations and getting those blood sugar readings back, providing a lot of education on diet, on exercise, all of those things. And that can take place during the visit, but then that also happens with both the telephone and electronically with email afterwards. And we were fortunate enough that we were one of 25 sites chosen nationally as part of an APHA, American Pharmacists Association project, to get pharmacists involved with diabetes. And they're running those numbers now, but the numbers look fantastic, that we're really improving outcomes by having the pharmacists directly involved with
Wonderful.
the care.
So we know that diabetes is one of our big chronic diseases
Right.
that affects our healthcare system.
Yep.
And I presume that you're helping patients adhere to their medication therapy better, understanding why they're taking it, how to monitor it, all
Yeah.
those things.
Absolutely, with our diabetes group. And then we also can just see, because we do have a pharmacist in the office, any physician that thinks that their patient is on too many medicines or is having problems with adherence, they'll set up a separate visit just to see us. And we'll go through all those medications and we'll check everything for interactions and for any adverse effects and make sure there's no duplications. And that patient that comes in for that visit will walk out and they will have a table of, here's the medications that you're supposed to be taking, and the physician has a better idea of what medications the patient's actually taking at home. So
Yeah.
it's a really nice service for our patients, I think.
Yeah, it is. Well, Stu, this is an interesting model, and through our kind of healthcare reform, this patient-centered medical home has been kind of an important piece of that. And I'm wondering, as you having worked in this model, and do you have any sense for how this will change opportunities for pharmacists moving forward, maybe this or even other aspects of reform? Because there are people watching this video who may be thinking about entering this field. How will this change the way they practice?
Sure, I think this is, what we are doing is going to be the future of pharmacy practice. And that doesn't necessarily mean that every physician office is going to have a pharmacist in it. I think you may see more physicians' offices that have a pharmacist in it. But even aside from that, that collaboration, that multidisciplinary care of taking care of patients. Something else we work on is transitions of care at our clinic and patients that have just been out of the hospital, and really trying to coordinate to make sure they don't end up back in the hospital. And just the model that we use, it works out well because we're in the physician office, but I don't see any reason that that same model can't be transcribed out to the community. And somebody that's working at a Walgreens, a Kroger, an independent pharmacy out there can be calling patients and saying, hey, Dr. So-and-so, your patient came to me, just got out of the hospital, here's all the things that I found out, and by the way, you're seeing them in a week and a half, this is what's going on with their medications. And I think it's really going to have a big impact on keeping people out of the hospital and keeping people healthier, that's what we're supposed to be doing.
You bet. So you hit on transitions of care, which has been an emphasis in our course, so that even strengthens that discussion. And the idea that healthcare reform is, all the aspects of it are interested in improving transitions of care.
Absolutely.
And it's a big deal in our healthcare system.
Right.
The last question that I had for you, Stu, relates to kind of the things you do. And so I introduced you as an assistant professor of clinical pharmacy, and you've described this clinical role you have in the internal medicine clinic. But you kind of wear two hats, probably more than two hats actually, but one's in the clinic and one's in the
Sure.
classroom. And again, there are probably people out there thinking, yeah, that sounds like an interesting career pathway. And career pathways is another emphasis of this week of the course. So can you kind of give us your take on this, the pros and cons, the challenges, the advantages
Sure.
that you have in doing these two things together?
Sure. I think the biggest challenge is that you're definitely wearing two hats, and I'm supposed to be 50% at the college, 50% in the clinic, and that percentage seems to kind of vary quite a bit depending on what's going on. So I am involved in teaching in some of the therapeutics courses, and I do have my own course that I help coordinate. But I guess the advantage is what I really think to do is I try to think of myself as a clinician first, and I'm really trying to help the patients. So if I have students on rotation with me, I'm trying to show them this is how I practice pharmacy and this is how you can impact somebody's life. If I'm lecturing to 120 students, I'm bringing those experiences in from my clinic to say, here's something that I've seen in the clinic, and this is what a pharmacist actually can do to impact a patient. So I really try to, as much as many hats as I'm wearing, as many balls are up in the air, I really try to think about everything that I'm doing as a clinician. If we're doing a research project, it's all revolved around what is it that a pharmacist can be doing to help healthcare, to move the profession forward, help patients out. And if I think about it like that, it seems like it's helped me over the years to really prioritize and figure out if that's something I should be doing.
Yeah. Well, I think it's a cool position myself, and I encourage students to think about this because you have the kind of the best of both worlds in some ways.
Yeah.
You have the practice, you have the academic connection. And you know, really, essentially what you just described, you've just done for the students watching this video. You've brought your experiences
Hopefully.
to bear to this classroom, right?
Right,
Yeah.
right. Absolutely, absolutely.
Well, Stu, it's been a pleasure having you with us.
Thanks a lot.
Thanks for coming.
Yeah, no problem.
Good luck to you.
Thanks.